Hello friends, this video is a continuation of the previous video on important questions on pediatric nursing. So today we'll see the other questions. So here the first question is define leukemia, the types of leukemia, and also they have asked for pathophysiology, clinical features, medical and nursing management of leukemia. So now we'll see the answers for this. First we will see the definition of leukemia. So leukemia is a group of malignant disorders affecting the blood and blood forming tissues of bone marrow, lymph system and the spleen. Next we will discuss about the etiology. Etiology is, although the exact cause is not known, the risk factors will include. Although the exact cause is not known, the risk factors will usually include genetic and environmental factors, chromosomal changes, for example, Down syndrome, any exposure to chemical agents, and sometimes when chemotherapeutic drugs are given, it can also be one of the risk factors for getting this type of malignant disorders affecting the blood cells. Certain viruses, exposure to the radiation and any chemotherapy agents, immunological deficiencies, and people residing near to this nuclear bomb sites are more prone for getting this type of malignant disorders, and those person who are having a family history of leukemia is also affected, is one of the risk factors. As you have seen in the questions, they have asked for the classification of leukemia. Leukemia is usually classified into acute and chronic, and it is also classified on the basis of which type of cells are involved. First one is acute leukemia. In acute leukemia, you can see that there is a proliferation of the immature hemophotic cells, and also you can see the bone marrows will not be able to produce an healthy blood cells, and the progression of the disease is very rapid, so immediate treatment is required here in case of acute leukemias. Chronic leukemias are which here the immature WBCs are formed at an higher rates and also resulting in many types of abnormal white blood cells, and it mostly occurs in older people. So again, based on the type of WBC, again leukemia is classified into acute myelogenous leukemia, acute lymphocytic leukemia, chronic myelogenous leukemia, and chronic lymphocytic leukemia. So in acute myelogenous leukemia, you can see the onset is abrupt and the incidence is usually between 60 to 70 years of age. Here you can see it is characterized by uncontrolled proliferation of the myeloblasts and also the precursors of basophils and eosinophils. Next is the clinical manifestation of this acute myelogenous leukemia. It is usually manifested as fatigue, weakness, headache, mouth sores, anemia, sternal tenderness, gingival aplasia, minimal hepatosplenomegaly, and lymphadenopathy. The next type is acute lymphocytic leukemia. It is the most common type of leukemia in children, and the peak incidence is from age of 2 to 9 years and also in the older adults. You can see there is an immature lymphocytes proliferates in the bone marrow. Next, the clinical features of lymphocytic leukemia, same like as we have seen in the previous one, but little difference will be there. Fever, pallor, anorexia, fatigue and general weakness. And also you can see there is a lymphadenopathy, weight loss, hepatosplenomegaly, headache, mouth sores was there in the previous one also, and here you can also see there is a bone and joint pain is there, abdominal pain also is there. Next, chronic myelogenous leukemia, it accounts for about 15 to 20% of all cases of leukemia. It is usually caused by exposure to benzene and also high doses of radiation seen between the ages of 20 and 60 years of age. It's also caused by excessive development of mature neoplastic granulocytes. neoplastic granulocytes, that means white blood cells with the secretory granules in the cytoplasm. And also you can see that there is an excessive neoplastic granulocytes in the peripheral blood infiltrate, especially in the liver and the spleen. The clinical manifestation of chronic myelogenous leukemia are usually it has no symptoms in the early stages, but later on it is manifested as fatigue, fever, sternal tenderness, weight loss, joint pain, bone pain, and massive splenomegaly. Next one is chronic lymphocytic leukemia. This type of leukemia is very common in adults and seen between 50 to 70 years of age. It is usually characterized by production and accumulation of functionally inactive but long-lived small mature appearing lymphocytes. The clinical manifestation of chronic lymphocytic leukemia is, you can see here, there is a chronic fatigue, anorexia, splenomegaly, hepatomegaly, fever, weight loss, and frequent infections. Next, they've asked for the management. So the management, you should write about the chemotherapy. The first stage is induction therapy. Here in the induction therapy, it is used to bring down the recession of the disease and also the remission. That's the first stage of chemotherapy, called as induction therapy. And the second stage is post induction or post remission chemotherapy, where it is followed by intensification, consolidation, and maintenance therapy. Now we'll see what is induction therapy. So in induction therapy, it is usually our aim is to destroy the leukemic cells and also to restore the normal hemophytic functions. The chemotherapeutic agents that is usually used here is cetarabine, and other anti-tumor antibiotics is used like daunorubicin, doxorubicin, and idarubicin. What is post-induction chemotherapy then? It is nothing but the intensification of the therapy, which is where we given immediately after induction therapy for several months. It includes the same drugs that was given in the induction therapy, but usually in an higher doses. I repeat, the same like the induction therapy, the same drugs are given, but here it is given at the higher doses. Next, in post-induction chemotherapy, we have consolidation therapy, which is started after the remission is achieved, and usually it consists of 1 or 2 additional courses of the same drugs given during the induction therapy, and also higher amount of the doses given, same like the induction therapies. The purpose of this consolidation therapy is to eliminate the remaining leukemic cells so that it will not come back again. Next, in the post-induction chemotherapy, we have maintenance therapy, in which the treatment is done with the low doses of the same drugs used in the induction therapy, but it is used for every 3 to 4 weeks or for a prolonged period of time. Sometimes, in addition to the chemotherapy, radiation therapy is required. That is, total body radiation therapy is done along, and sometimes bone marrow transplantation can also be done in uncontrollable leukemias, and in case of ALL, intrathecal administration of methotrexate or cetarabine is given to decrease the chance of CNS involvement. So what is ALL? ALL means acute lymphocytic leukemia. Next, we'll see the nursing management for leukemias. That is, first of all, we should assess the general condition of the patient and closely monitor the lab values that we get every day. Maintain good interpersonal relationship with the patient and the parents of the child. Provide psychological support and monitor vital signs. And also ask the child, if it's an older child, we can ask them to have a well balanced diet. In other children, we need to take care of them. And always include the family members in providing care, and explain the side effects of chemotherapy and radiation therapy. Administer antibiotics, maintain aseptic techniques, because these patients are more prone for getting other infectious diseases because their immune system is always weak. And also we should provide a proper isolation to the patient and provide health education to the parents here. So nursing diagnosis goes like this. First is imbalanced nutrition, less than body requirements, related to inadequate nutritional intake and anorexia. Activity intolerance related to weakness and imbalance between oxygen supply and demand. Also impaired oral mucous membrane related to low platelet count. So whenever they are asking leukemia for 10 marks, we should always write it in the form of a care plan. Write this diagnosis and write the things in the form of a care plan. So the next question they've asked is about the preterm babies. Mention the physical and neurological characteristics of preterm and also the nursing process of hospitalized preterm babies. Now we'll see the answers for that. So preterm babies are the babies born before the completion of the 37 weeks, calculating from the first day of the last menstrual period is defined as a preterm babies. And these babies are usually born before 37 weeks, usually weighing about 2500 grams or less. So they are considered to be as a preterm babies. So if you see the etiology, it is usually divided into spontaneous and induced. Means sometimes the preterm delivery occurs in a spontaneous thing, and the other times the delivery may be induced uh, before the completion of the term, maybe because of some medical reasons or any disease conditions. So we'll see the causes according to this, both the spontaneous and induced, in which case it is spontaneous and in which cases it is induced. So sometimes what happens is delivery occurs spontaneously in preterm itself before the completion of the term. Maybe it is because of the following reasons, like maybe because of multiple pregnancy, and if the health status of the mother is too weak, and advanced parental age, some problems related to placenta, preterm labor or premature rupture of membranes, where the pain starts very prematurely, and also the membranes get ruptured early. And also it may be because of low maternal weight, chronic and acute systemic maternal disease, antepartum hemorrhage. Sometimes it may be because of the cervical incompetence, maternal genital colonization and infections, cigarette smoking during pregnancy, acute emotional stress, physical exertion, trauma. Bicornuate uterus means it is a congenital disease affecting the uterus. Next is the induced cause. The induced cause is it may be because of maternal, means when the mother is suffering from any of this following conditions and it is very severe, the delivery may be induced. So the reasons for that are maternal diabetes mellitus, placental dysfunction, unsatisfactory fetal growth, eclampsia, fetal hypoxia, antepartum hemorrhage, and severe RH isoimmunization. So these are the reasons for induced preterm delivery. Next, as you have seen in the question, they have asked for the clinical features of this preterm babies. Usually they measure in small in size, and their head is also relatively large. The length of the babies from crown to heel is less than 47 centimeters, and head circumference is less than 33 centimeters, but the chest circumference exceeds more than 33 centimeters. So here circumference is less than 33 centimeters, but exceeds the chest circumference by more than 33 centimeters. Activity and posture. If we take up the activity and posture of this preterm babies, their activity is very poor, and also they'll have automatic reflex responses such as Moro response, sucking and swallowing reflex. But when they have reflex, but they are very sluggish, and sometimes it can be incomplete. And babies usually assume an extended posture due to the poor tone. As you can see in the head and the face appears very small and large head size, already told. Sutures are widely separated. Fontanelles are larger when compared to the normal terms. Small chin, protruding eyes, and optic nerve is usually unmyelinated. And ear cartilage is deficient and sometimes absent. And hair appears woolly and fuzzy, and individual hair fibers can be seen separately. The skin and the subcutaneous tissues, the skin is very thin, gelatinous, and shiny, and they'll have excessive amount of lanigo on their skins and very little amount of vernix caseosa, because the vernix caseosa is formed at the last term of the embryonic development, and the edema is usually present, and subcutaneous fat is usually deficient, and breast nodule is small or sometimes completely absent. The genitals, male babies, testes usually undescended, and scrotum is poorly developed. In the female babies, you can see labia majora is widely separated, exposing the labia minora, and you can also see there is an hypertrophic clitoris. So, in the skin, already told that skin, the cartilage, ear cartilage is soft and pliable. Soles and palms have minimal creases, and they'll have a smooth appearance. They'll usually have a scarf sign, means elbows may be easily brought across the chest with little or no resistance. Usually very difficult to get manifested for the term babies. The male genitalia, I already told you, the scrotum is undeveloped and testes usually undescended. Female genitalia, that is labia majora, is poorly developed, exposing the labia minora. And clitoris is also hypertrophied here. So in the central nervous system, usually the central nervous system is immature. They'll have poor cough reflex. They'll have uncoordinated sucking and swallowing, means they don't, once they suck they should swallow, but they'll not have this coordination because they are still premature. They'll usually have retrolental fibroplasts will be there, and they'll have intraventricular and periventricular hemorrhage. In the respiratory system, they'll usually have difficulties in breathing, and they may require resuscitation at birth. And they are more at risk of developing hyaline membrane disease. Breathing is periodic and associated with use of intercostal recessions, and also there is a chance of pulmonary aspiration and atelectasis in bronchopulmonary dysplasia. So just because there's a review of question and answers, I'm not explaining each and everything. I'm just reading out the answers for you, and sometimes I do explain. Cardiovascular system, the closure of the ductus arteriosus is delayed. In the GI system, you can see there's a more prone for regurgitations, abdominal distension, intestinal obstruction is more common. They'll have a high amount of colitis, enterocolitis, and hyperbilirubinemia and hypoglycemia. In thermoregulation, they'll have excessive amount of heat loss. They are more prone for getting infections because their renal system is immature. They'll have high amount of blood urea nitrogen, and they'll also have acidosis and edema. And also they'll have nutritional problems, like they are more prone for getting anemia, deficiencies of folic acid and vitamin E, and osteopenia is very common among them, and also followed by rickets. They'll also have biochemical disturbances like hypoglycemia, hypocalcemia, and hypoxia. So they have asked you for the nursing management of this preterm babies. First of all, how to take care of a preterm babies, and what is the intensive care protocol for them. First of all, you have to care for them like a normal newborn. They should have a high cushion bed. Avoid excessive light and excessive sound because they are more sensitive to these things, and also we need to use analgesia and sedation for procedures. And we should always make sure that we are following aseptic precautions whenever we are doing the procedures for them, because they are more prone for getting infections. Cover the baby appropriately because they are more prone for going into hypothermia very quickly. Provide effective and safe oxygenation. Nutrition should be maintained very thoroughly, and sometimes the NG2 feeding is required because their sucking and swallowing sometimes is incoordinated. And always provide them with the tactile and kinetic stimulation for them. And phototherapy may be necessary if they are suffering from hyperbilirubinemia. Try to prevent nosocomial infections and record the weight regularly. Immunizations should be followed. Family support is very much necessary, and always follow discharge policy, and also follow-up care is most important, and teach the parents after discharge how to take care of the preterm babies at home. So we have seen three most important questions. The most important question that is asked from the previous year question paper. So if you like this video, please do like, share and comment. Thank you friends. Meet you in the next video. Thank you.